Moving towards our next scientific affairs, that will be a gripping panel discussion between two eminent consultants, and the topic is diabetes and lungs, the causes and consequences. We have our two eminent panelists with us, Dr. Arnab Saha, consultant pulmonologist, associate professor, Badwan Medical College. He is also attached with Narayana Super Specialty Hospital, Howrah, and Dr. Agniva Maity, associate professor, SSKM Hospital, Kolkata. Okay, there will be another person who needs no introduction actually, Dr. G.P. Bhattacharya.
Good afternoon, everybody. It's a post-lunch session, and we may be feeling dizzy after having a sumptuous lunch. But our patients suffer both from diabetes and airway diseases. We all know that diabetes is an inflammatory disorder. And any inflammatory disorder has some chronic consequences. Diabetes has consequences on nerves, heart, kidney, liver, we all know. It must be having some consequences on lungs also, but this area is not very much clearly studied or known to us. We have in our panel Dr. Arnab Saha. He is a consultant chest physician. Dr. Agniva Maity, he is a consultant physician. And the topic will be diabetes and the lung disease. Agniva?
What is the lung function abnormality? I just first want to just discuss about this topic. I will just request Dr. Shah to highlight in this topic. What are the lung function abnormalities generally we get in diabetic patients?
Compromised lung function is a common entity in all our diabetic patients. It, as Dr. Bhattacharya said, that diabetes is a chronic inflammatory state. So also it leads to increase the oxidative stress. That's why the obstructive airway disease, chance of obstructive airway disease is much higher in a non-diabetic patient. So at least if any symptoms of shortness of breath or chronic cough in your non-diabetes patient, we should check the lung function test and to lung function screening to early identify the obstructive airway disease. Agniva, any challenges you face to manage diabetes in case of non-COPD patient in your clinical practice?
Actually, COPD is a chronic inflammatory state. So there is increased IL-6 and there is increased tumor necrosis alpha. So this all leads to a chronic inflammatory states. So there is gradually, with the course of time, there is chance of development of insulin resistance. So we get insulin resistance mostly in these COPD patients. And in COPD patient, when there is an exacerbation, we have to use corticosteroid. That is also in that period also, there is a role of controlling the diabetes. For the time being, we may have to put the patient on basal bolus insulin regimen. So insulin resistant, so diabetic management and diabetic control is really challenging in this group of patients, as there is a chronic inflammatory state and there is insulin resistance. And when there is on-off, there is exacerbation of the disease and we have to put the patient on the steroid. In that time also, we have to be cautious and we have to, from oral hypoglycemic agent, for the timing, we may have to shift to the subcutaneous insulin therapy. And if this glycemic status is not properly controlled in this group of patients, then there is chance of recurrent exacerbation also. Patient may suffer from recurrent exacerbation also. So to prevent this recurrent exacerbation, we have to be very cautious. We have to be stringent in the guideline, and we have to be control the blood sugar very strictly in this group of patients. And next, I will just want to ask Dr. Arnab, and what is the relation between diabetes and pneumonia? Why pneumonia is more aggressive, and what are the organisms mostly we get and in the therapy, and why pneumonia behaves more aggressively in these diabetic patients?
As we all know that diabetes it increases the systemic inflammation. That's why in case of known diabetes, especially uncontrolled diabetes, pneumonia acts more aggressive. The most common organism usually we found that's staph from gram positive, and gram negative we found E. coli and Klebsiella pneumoniae. And one thing we should keep in mind that the vaccinations in your diabetes patient, all the diabetes patients should be vaccinated properly.
Vaccination, what is it?
And the guideline of Midullah.
Which is that if there is any relations between the diabetes and the lung. So I have recently published a paper where I have shown that there is an increased incidence of diabetes in a particularly in the patient who are suffering from COPD, taking the inhaler, either corticosteroid inhaler, or you can say the patient is having LABA-LAMA combination or LABA-ICS combination. So I think in the vice versa also, the patient have diabetes, have more propensity, more increased risk of suffering from COPD. In my paper, I have published, I have taken 52 subjects, and that has been admitted in just I have been seen in the outdoor, in the NSH or NMH. So there is a direct relationship that if the patient is COPD, suffering COPD, so there is increased incidence of new onset diabetes, and also the patient is having diabetes, there is increased chance of COPD. So what is your take? If you have seen something like that?
Already Agniva has told that a chance of getting COPD in known case of diabetes, there is a pathogenesis of the tumor necrosis factor, IL-6, etc. But in case of COPD, the guideline from GOLD, it is clearly mentioned that if the eosinophil count is high, only then you can use inhaled corticosteroid. Although there is very less chance of diabetes in case of inhaled corticosteroid, if you are not using systemic corticosteroid, chance of getting your chance of
systemic absorption is less.
Yes, systemic absorption is very low. So chance of uncontrolled diabetes mellitus is very low. But although if the eosinophil count is low, you should avoid inhaled corticosteroid in case of COPD.
Would you recommend this in case of frequent exacerbators? Frequent exacerbators, stage E of
Yes,
GOLD
yes.
guideline.
In case
with
of
low eosinophil count.
Yes. So always follow the eosinophil count. If the eosinophil count is low in case of also frequent exacerbator group, that means group E, you should avoid inhaled corticosteroid.
So another question. So suppose the patient admitted with a pneumonia, and patient is had
Obstructive
history,
airways.
patient had history of, patient has admitted with a history of pneumonia, and patient had history of COPD and diabetes also. So in every patient, so suppose the patient was admitted in the ICU, so you have to give the patient the nebulizations. So will you recommend this patient of pneumonia with the background of COPD and diabetes, will you recommend it to inhalation steroid, or you will go for the systemic steroid?
There is a catch.
Yes.
If the patient is a known case of obstructive airways, you don't know whether it is COPD or it is asthma, you don't know. Only there is a history of obstructive airway disease.
Yes.
Okay. So if your eosinophil count, only eosinophil percentage in your CBC, if it is more than 2%, you can add inhaled corticosteroid. But if it is less than 2%, if possible, you should avoid inhaled corticosteroid in those patients also.
But suppose the patient is having COPD, admitted with pneumonia, so you will avoid giving inhalation corticosteroid in that patient. Am I right?
Yes, yes, absolutely,
And
absolutely.
the patient is having pneumonia, probably has got the acute exacerbation of COPD. In that group of patients, we often use the systemic steroids. So in a systemic steroid when it's given, that there is definitely the hyperglycemia will be increased.
Yes,
so
yes.
in that case, whether you go for inhalation corticosteroid or systemic corticosteroid.
Systemic corticosteroid. Yes.
that one.
But in that case, you need to alter your diabetes
And
management.
what about the vaccinations? So the recent guidelines say that we are giving the patient a flu vaccination, because if the patient is having diabetes, every guideline says you have to give the flu vaccines, and probably the age is no barrier. But if the patient is having diabetes and COPD and the patient is having the more than 50 years, we have to give definitely the pneumococcal vaccines, and also that is the PSB 13, PCB 13 and PSB 23. Now the other recommendation is that we have to give the Shingrix vaccine, that is the varicella zoster vaccine. So what is your take? Particularly the Gold has recommended that you have to give the varicella vaccine, varicella zoster
Yes,
vaccine
yes,
to
yes.
everyone. So
There is-
are you
yeah.
giving this patient this varicella
There
zoster
is clear recommendation regarding the varicella vaccine, but in our day-to-day practice, cost is a big factor. So I cannot comment on that, but if possible, you can add varicella vaccine to your scheduled vaccination.
And what are the organism actually we get? And another thing, just to I just want to highlight, apart from the all immune system and the innate immunity, that is chemotaxis, phagocytosis, that is affected in the diabetic patient, and there is some role of increased adiponectin, and there is exacerbation of various type of this disease. There is, so this, as this immunity is very much compromised, this innate immunity, there is phagocytosis, and there is chronic inflammatory state, increased CRP, increased IL-6. So these two factors is very much responsible for aggressive behavior of this pneumonia and frequent exacerbation of COPD in the diabetic patients. And there is a, can you just highlight about there is a chance of development of, frequent chance of development of pulmonary hypertension in the diabetic patient? Can you just highlight?
In your clinical practice, I have already told that the compromised lung function is very much common in case of diabetes. I am just giving an example of your day-to-day clinical practice. Suppose if you have uncontrolled diabetes patient and the patient is having shortness of breath, or might be he or she have controlled diabetes, and you check their lung function, check X-ray, all are normal. Echo is also normal. But patient is getting exertional dyspnea. So what will we do? Please, in that case, write echo Doppler with pulmonary arterial systolic pressure to find out the pulmonary arterial hypertension, if your patient is having this kind of disease or not. This is very important, because diabetes, we all know that it leads to microvascular or macrovascular injury, and which also leads to hamper the pulmonary vasculature. So chance of getting pulmonary hypertension is more in case of diabetic hypertension, in case of diabetes.
Highlight about the management of this.
No, if you going to management part, it is different. If there is a type 1, that is idiopathic pulmonary hypertension, there are a lot of management guidelines. But if the pulmonary hypertension is due to any lung cause, so you should find out the main reason is hypoxia or not. If it is hypoxia, treat the hypoxia part, not just use the vasodilators. So that is very important. And if your left ventricle is compromised, so you need to control the left ventricle, or you can use the vasodilators, mostly sildenafil or whatever. But if there is idiopathic pulmonary hypertension, there is definitely a recommendation of the vasodilators.
Fungal infection, any highlight?
In both the cases of either idiopathic pulmonary hypertension and a long-term pulmonary hypertension, the patient was having the same type and presenting the same symptoms. And echo shows the same type of raised pressure or not.
Echo?
No, pulmonary arterial systolic pressure might be increased in both the cases. Okay, so echo cannot rule out the whether it is due to the lung cause, whether it is due to idiopathic. Echo only suggests whether left ventricle is involved or not, or right ventricle involved or not. That is the catch.
And but tricuspid regurgitation jet, TRJ, we have to see in the echo. TRJ.
Just comment on the invasive fungal infections more common in diabetics. I'm not, I'm asking you.
Aspergillosis, mucormycosis, and in COVID
common.
times there is a hype of mucormycosis.
Mucormycosis, so liposomal amphotericin B we have used a lot in case of mucormycosis, but nowadays a chance of getting mucormycosis is very low. I don't know.
Aspergillosis sometimes we get.
Yes, invasive aspergillosis sometimes might occur in case of uncontrolled, especially in uncontrolled diabetes, not in controlled diabetes. If there is long-term, there is poor glycemic control status, so chance of getting invasive aspergillosis, there is clear-cut sign in case of X-ray or CT scan. Okay, so hello sign.
CT scan we get.
Just any thumb rule of starting oral corticosteroid in a known case of diabetes or more than 20 years, having history of smoking. Patient has CSF, try to sedate, try to minimize his smoking habit, but with recurrent pneumonia or maybe the COPD. Every time patient is not ready to admit or not go for the lung function. What is the initiation of corticosteroid?
Get you. No. So what is the dose of corticosteroid in case of COPD or?
What are the doses? Doses and duration. COPD
Okay,
and diabetes.
okay.
What are the
If there is if your patient is having exacerbation of obstructive airway disease, it might be asthma, it might be COPD. If there is exacerbation, you need to add systemic corticosteroid. If patient is having uncontrolled diabetes, I am not giving systemic corticosteroid, that not be your concern. So you need to change your anti-diabetic management, you need to increase your anti-diabetic management, but you need to control your obstructive airway disease exacerbation. That's very important. Yes, very important message. So definitely you should use corticosteroid, but for recommendation is for only 3 to 5 days, whatever the exacerbation is, not the tapered dose. Again, previously we used to use the tapered dose, 1 milligram per kg per day, then 0.5. So but nowadays the recommendation is the abruptly stop your corticosteroid dose.
Diagnostic criteria and management.
Diagnostic criteria of, no. If there is any patient is having dry cough for 5 to 6 days, you should suspect atypical pneumonia or viral pneumonia. Okay, but if your patient is having purulent expectoration or mucoid expectoration, you should suspect the typical pneumonia organism. Okay, and if there is atypical pneumonia, according to the community acquired pneumonia is Yes, yes. If the patient is having dry cough, the viral cough or atypical pneumonia cough is much more common. Okay. So if you suspect if the patient is having atypical pneumonia, you should you should add clarithromycin or azithromycin in your practice. And if you find the Indian pneumonia guideline, in case of any community acquired pneumonia, you should add atypical pneumonia coverage.
The time is up. We are now concluding. Diabetes is an inflammatory disease. Whenever there is need of steroid, you should give steroid. If there is a strong suspicion of pneumonia, you should give less dose of steroid. But if the pneumonia suspicion is less, you should give high dose steroid, but that should be ended by 5-6 days. And in my opinion, you should cover it with insulin. If not possible, you can add DPP-4 inhibitor group of drugs, which are very effective in case of combating hyperglycemia induced by the insulin. Thank you. Let us conclude the session.
Thank you so much, sir. It's time to facilitate the two eminent consultants over there as panelists. I would like to request Dr. G.P. Bhattacharya to please felicitate them. Thank you so much.